Hi, good morning. Welcome to this episode of Guts and Glory, wherein we speak to the experts and unravel the mysteries of complex GI problems. Today I have Sudeep Shah. Sudeep is a longtime friend. He is a GI and HPB surgeon at PD Hinduja Hospital, Mumbai. He is a very active member of the IHPBA community, both Indian chapter, Asia Pacific, and the international IHPBA. He's also an associate editor of Indian Journal of Surgery, which I think has made tremendous progress over the last decade or so in terms of the quality and the nature of publications. But to me, Sudeep exemplifies the fact that his very articulate and analytical assessment of clinical problems and the fact that he presents it in a very manner which simplifies the complex concepts of GI surgery. And actually, that is what makes him a much sought after speaker in all professional forums. And we are going to, talk about a very interesting topic, which is how the landscape has changed in terms of management of liver tumors over the last decade or two. And I had very interesting conversation with Sudeep, and I thought we'll share this with our viewers. So the paradigm shifts in management of liver tumors over the last decade or so. So Sudeep, welcome to this podcast, and I hope we'll have an engaging conversation.
Yeah, thank you, Sadiq, for that very kind introduction. And I'm sure that this will be entertaining as well as educative.
Great. So, Sudeep, as we were discussing uh, before this podcast, and were very clear about the fact that two things, tremendous change in the landscape of management, diagnosis of liver tumors. And you also emphasize the second thing that it requires a constant updating of your knowledge and skills. So just elaborate on this that what makes you feel things, what has changed and how it has impacted the management of liver tumors.
Oh, absolutely, Sadiq. As you're well aware, the world itself is changing. Who would have predicted the internet? Who would have predicted where we are today with computing? Who would have predicted social media and the availability of videos? Who would have predicted the free flow of information, correct as well as incorrect? And all this has impacted liver surgery like nothing else. As you're well aware, Sadiq, liver is a complex organ. If you look at it when you open the abdomen, you just see a brown blob in the top upper corner. It looks very simple and plain on the outside, but the inside is a complex series of cables carrying blood vessels, bile ducts. The outflow is so complex. And, the books will tell you standard anatomy, but as surgeons, we all know that there's so many variations within.
Absolutely.
And a cut in the wrong direction causes horrendous bleeding because 25% of your blood is within your liver at any given time. So, to unravel this anatomical mystery is something which imaging progress has really taught us. And similarly, it's not just about the structure, it's about the function. The liver is kind to surgeons because it grows back so beautifully. So you can, take out 70% of a healthy liver and you can have a patient strolling around the ward and, coming back to your
Yeah.
OPD absolutely fine. On the other hand, you have a liver which is touched by chemotherapy or fat. You find that you have huge problems. So
Yeah.
to look and determine before you start cutting the function of the liver is another challenge. Similarly, the ways that we can insult the liver have also changed over time. When we were residents, hepatitis C did not exist. You remember there was an entity of non-A, non-B
Non-A, non-B.
hepatitis.
Yes.
Today, the residents would be amazed if you use that terminology. So
Absolutely.
hepatitis C came in down the line, and the history of hepatitis C itself is so dramatic. When I was training in transplantation, 30% of our transplants were for hepatitis C.
Mm.
Today, you would find that even the HCCs because of hepatitis C have diminished so much because the 12-week course of tablets has
Yes.
just eradicated the virus in so many patients. So
Right.
the changes have been not only in the ability to see within the liver with diagnosis, the ability to determine liver function. The scenario that we are dealing with is changing so rapidly that we
Yes.
really need to keep up with what is the right thing to do for each patient. And even surgery is changing. From the open laparotomy or on laparoscopic surgery, liver transplantation has made such tremendous strides in this day and age. So every aspect of liver surgery is dramatically changing, so which really needs us to keep up to date.
So let's take this one by one, Sudeep. I mean, the most important and fascinating thing is diagnosis and
Yes.
imaging. So again, take us through the evolution.
Absolutely. Ultrasound. Even ultrasound technology has dramatically increased. But I must say that ultrasound has stood the test of time. And ultrasound intraoperatively is probably still a great weapon that we have today. But
Yeah,
ultrasound has its limitations in telling us function, and it has its limitation in telling us an overall, view
3D
of liver
anatomy.
anatomy.
Yeah,
So the dramatic use of X-rays to give us cross-sectional imaging, 2D reconstruction and 3D reconstruction is what has dramatically changed how we visualize and plan liver surgery. And technology has galloped so much that now the simple pixel with your multi-slice, multi-detector CT has become a voxel, a three-dimensional cube which can be rotated. Your multi-planar reconstruction.
yes,
So it's almost like peering inside the model of a structure. And you can now put on your software colors, you can color the vessels, you can color the bile ducts, you can color the tumor, you can accurately measure volumes, you can do segmental anatomy, and you can even virtually cut the liver so that you can plan before you go in how much volume remains. Then you have advances of MRI, which tell
mm,
you function. MRI will also tell you, diffusion weighting, I think, is a dramatic advance in telling you the potential of tumors within the liver. So if you have a post-chemotherapy liver surrounded by fat, you may not see the tumor so well on a CT scan because the densities are similar. But,
yes,
with diffusion weighting, they just light up like a tube light. I mean, PET scan is something that we can discuss as a separate modality. Lots of
yes,
pluses, lots of minuses with PET scan as far as this entity goes. Contrast ultrasonography, use of
mm,
intraoperative ultrasonography, and of course, marrying all this information together to give you a very good preoperative plan of where you're going to cut, what it's going to look like at the end, keeping enough inflow to the liver, outflow to the liver, and having a good volume of liver where we can be assured of regeneration in the postoperative period as long as the surgery goes well.
part, firstly, about how much impact it has made on diagnosis. And
Absolutely.
I want to hear from you that, oftentimes we sort of wrestle in our mind that what is the best imaging in this scenario? So when do you do a CCT? When do you do a MR, contrast MR, diffusion MR only, or when do you do both? So can you
Absolutely.
just elaborate a bit and
Yes.
simplify this for me?
Right. So, it's a matter that I would divide it into two. You have screening and you have diagnosis of an existing problem. A large proportion of patients who come to us are cirrhotics who are under surveillance for hepatitis B or NASH. It is obviously impossible to do, a complex imaging on them. So a good quality ultrasonography and an alpha fetoprotein by a radiologist who's skilled in doing liver ultrasound would give you an idea that something is changing. If the patient has already had a tumor which is resected, we obviously cannot subject this patient to radiation repeatedly for 5 or 10 years at a stretch. So, MR of the liver is a wonderful tool as long as the patient is not claustrophobic to monitor the patient over a period of time. Now, once we know there's a liver tumor and we are planning whether surgery should be done and how the surgery should be done, the reconstruction that we can get is best done on a high quality multi slice CT scan. So the what we depend upon today as far as imaging goes, CT will always be the gold standard in our current practice. Then there are specific problems that you wish to solve. There might be doubts whether you're looking at a regenerative nodule or an HCC. So MRI is very, very useful in troubleshooting. You might have chemotherapy for a colorectal metastasis. The metastasis seems to have disappeared on the scan. So there again, MRI and DWI would be very, very useful. You want a relationship with biliary anatomy. And we are not discussing cholangiocarcinomas today, but if you're looking at biliary anatomy, MR cholangiography is another spectacular tool. And the brilliance of our software today is that we can marry the MR cholangiography onto the CT reconstruction. And you can get such lovely composite images. So we need to have the best possible information before we go in.
So, do you have any sort of example of a case wherein, as a detective, you went from one to another and eventually got a. Why I'm asking is that there are times when a CT shows a lesion, but we don't know what it is.
Absolutely.
And there is a cascade of investigations which goes on. So how do you sort of proceed in that to get to
Absolutely.
the.
So, so we have had patients where they've been told they're inoperable because they're lesions in both lobes of the liver. And then you do an MRI to better characterize because one of the lesions looks a little odd. And then you find that it's just a complex liver cyst or what we call a von Mayenberg complex, which is a biliary cystadenoma
Hmm.
complex, just an aberrant biliary duct system within the liver. So that
Right.
will not preclude resection. So anything that looks a little bit odd, doesn't fit in your clinical picture, MRI would be troubleshooting. We have had the converse happening that we've had people, who've been actually told that, yes, you should go ahead and have the operation. And then you do, a contrast MR because it's post chemotherapy colorectal mets. You find that there are multiple lesions in the liver. PET scan becomes a hugely problematic issue. And I have examples of a patient where it was an HCC. And the person who reported the PET scan said that there's no PET uptake in the tumor. Now, we
Hmm.
know that PET is very good for colorectal cancer, liver mets, invariable uptake in those tumors. But 60% of HCCs do not have uptake on PET scan, right? So it's a good feature because that means they're well differentiated HCCs.
Yes.
The reason being that hepatocytes have an enzyme called hexokinase, which breaks down the glucose 6 phosphate, which allows the FDG glucose to escape back from the tumor into circulation. So it would be negative on PET. But because of that, the radiologist had written at the end of the report that this favors a benign pathology. Now, when the patient read the report, he said, Yippee, this is a benign pathology. He does not understand the
Yeah.
nuances of this favors. He
Yeah.
does not understand what an HCC is. So, just a line written in the radiology report made this chap say, now, why do I have to waste money consulting the doctor again? He just went home. And 6 months later, you come back with portal vein thrombosis and something which, we have regrets also about the way imaging has been interpreted. It's not the fault of the imaging modality. We need
Yeah.
to understand the nuances of each imaging. I have another story of a patient who had a pancreatic mass and had a rather difficult stenting. And the endoscopist probably didn't reveal that there was a stent block and cholangitis, stent change, referred to a very, very famous surgeon. And the PET scan was done. And they said multiple liver lesions suggestive of liver metastasis. So the gentleman was told that, there's no hope for you. Both lobes are full of tumor. And, nice knowing you, write your will. Went to the oncologist, took chemotherapy. And obviously, these were cholangiotic, abscesses within the liver. And
Hmm.
3 cycles of chemotherapy later, you have a scan where everything has disappeared. So they congratulated the oncologist on the brilliance of your treatment. Then
Hmm.
someone told them, take a second opinion. We tried to explain to the patient that, you still have a window that was probably cholangiotic abscesses. But
Hmm.
then, in their mind, a big person has told them that it's inoperable. They have thought that chemotherapy has melted everything. said, who wants to undergo a surgery which has a small chance of mortality and a huge morbidity? I'll give my chances to chemotherapy. And everything was lost just because of the way we are interpreting images.
Yeah. So, I mean, clearly everything has limitations, and that is what you need to understand. I think each
Absolutely. And
investigation
everything is
has
complementary.
its, yeah, and we have to use it in a complementary manner. So, when do you do a PET CT in HCC?
HCC, in my routine practice, there is no role for PET CT in an HCC. Uh, if a patient is being referred for a transplant, you want not even a 1% chance to escape. So there a PET CT would be done. So it's a very good whole body scan. You don't have to do a separate CT chest and a bone scan. And
Yes.
sometimes you find periportal nodes in an HCC where you can do an endoscopic ultrasound guided biopsy. You find HCC cells in that. The patient is not for transplant. So for colorectal mets, of course, it is excellent to see the whole body. You get an adrenal deposit, peritoneal deposits. You can see that quite clearly on PET scan, but not for the HCC, Sadiq.
Yeah. So, let's add one more dimension to this diagnosis. How do you use tumor markers? And the million dollar question, which a surgeon and a physician differs on, which is a biopsy of the lesion.
Yeah. So these are interesting questions, Sadiq. So for an HCC, we know that a very high alpha fetoprotein, if you have a value above 400, that would definitely be adequate to say that it's an HCC. You don't really need
With the imaging.
anything beyond that.
Yeah.
So match with the imaging. Now, again, if you have an AFP which is normal, that tells you nothing because 40% of HCCs will have a normal alpha fetoprotein. As far as colorectal metastases go, CA is a fantastic tool in the postoperative period because the jump in the CA is the first sign that there is trouble. Of course, normalization of tumor markers postoperatively is a very good sign that you've done a perfect job within your surgery. So they are excellent complementary tools to our armamentarium in as far as surgery goes. The other question that you had about the biopsy is very interesting. Um, a biopsy is can be done safely with a low risk of tumor seeding as long as it's done by a coaxial technique. However, there will always be a small degree of risk of bleeding and tumor seeding. And however small it is, the question we have to ask ourselves is what is a biopsy going to change? Now, we very well know that between a well differentiated HCC and the regenerative nodule, it it is almost impossible on histology to differentiate between the two. So
Yes.
giving a false hope to the patient that it's a regenerative nodule on a biopsy which may not be representative of the entire tumor would be incorrect. So the
And
reason to biopsy an HCC, yeah,
more than that, I think it is the false sense of security that
security
patients
which
have.
you which the
But,
patient has.
they say, but the biopsy is not showing that. What to
Absolutely.
convince them that it may be only, obviously, it is targeting only one part of it.
So the
Yeah.
sensitivity and specificity of a CT and an MRI combined would be maybe in the region of 90%, while a biopsy would only have a specificity of 70% in this. And FNA and aspiration cytology is a complete disaster in this setting because you don't even have the architecture to be able to guide the pathologist. So it adds very little to our HCC diagnosis. The only time where our HCCs are biopsied is where it is inoperable. So there, the patient wants certainty. You want closure that this is indeed a tumor, nothing more can be done. So a biopsy is useful.
So, Sudeep, actually, if the diagnosis is evident, clear on imaging,
Yeah,
supported by tumor markers, and if it is, I'm for the time being using resectable, that if it is you're going in for surgery and it is resectable, you need not do a biopsy.
absolutely.
If you are planning a downstaging, if you're planning or it seems unresectable, or
Yes.
there is a doubt in diagnosis on imaging, that may be an appropriate case for a biopsy.
Absolutely, which
That's
can
where
be safely done.
it
Yes.
can be safely done. And always do a FNA-B rather than a FNA-C.
AC and use a coaxial system where you have a cannula puncturing the liver through which the true cut needle goes. So you don't have, you minimize your risk of
Minimize
seeding
the risk of.
rather than a direct puncture. And always through normal liver rather than a direct tumor puncture where the capsule can rupture and you can have a ruptured tumor at the end.
As we discussed, that imaging has made a great impact on how we do the surgery. Uh, it would be fair to say, at least in my experience, that you do almost all the surgery outside on the images, and then you try to replicate that
Absolutely.
patient this thing in modern day with all the things available to you. You see a tumor with that being HCC in a cirrhotic.
Yes,
Now, how is your thought process? What is the final plan for this patient?
absolutely. So the basic principle of surgery is firstly to ensure that you're removing all the disease from the body. So you need to have your metastatic workup, which I think we've discussed a bit as far as the scanning goes. So it would be a CT chest and abdomen as far as I'm concerned. And the bones can be looked at as part of the CT protocol. We would then look at, are we leaving enough functioning liver, which has good drainage and a good inflow, with adequate volume based on the cirrhosis. So if the patient is a child's anything other than a child's A plus cirrhotic, that means he's got significant portal hypertension, or he's child's B or child C,
Hmm.
then I would be very conservative and there is no chance that this patient will have a liver resection. So the function is the next thing to gauge.
Right.
Once we know that he's got good function, his platelet counts are above a lakh, he's fit, he's well, right? Then the question is, can I leave 40% of the liver or more behind? The principle would always be to do an anatomical liver resection. And our understanding of anatomy has also dramatically evolved. So today, with the Tokyo modification of the Brisbane classification, as you well know, in 2000, the surgery was hemihepatectomy, sectionectomies, segmentectomies. Now we have the concept of the cone segment of liver anatomy. So even within the liver architecture, in segment 8, you will have maybe A and B. So each individual portal vein branch will have a cone of liver going around it. So
Hmm.
the principle would be to remove the whole cone with the portal venous branch which is supplying it. So that in case there are microthrombi from the HCC within the branch, that too is removed. So as far as possible, we would aim for an anatomical segmentectomy, sectionectomy, or a subsegmentectomy, cone segment resection, so that we can get its HCC out.
So
Now, the
portal
margin in
vein
an
based
HCC,
resection. Portal vein
absolutely, sir,
based resection.
and anatomically based resection.
Yes.
Now, the margin is an interesting concept here because we know from literature that you don't need a big margin for HCCs. So, a well encapsulated HCC, which is impinging a major blood vessel, you can have a zero margin resection, which will be curative, as long as you can see a very good capsule on your imaging. Intraoperatively, we have tools like ICG now, which can plan sections of the liver. And of course, the good old fashioned intraoperative ultrasound can
Ultrasound.
map each and every vessel within the liver.
You talked about anatomical resection for HCC.
Yes,
Margins being, we'll talk about margins, but is just clear margins is good enough, or 1 millimeter
absolutely.
is good enough. How is it different, say, in a colorectal metastasis, the
Right.
resection?
So, in colorectal metastasis, these microemboli in the portal vein aren't really a big issue.
Problem.
The
Not.
issue is that, these metastases, as you know, are very soft. They're not very well encapsulated. They tend to be irregular. And in this planning, you can easily do non-anatomical resections. The current concept would be something called parenchyma sparing. So you leave as much parenchyma behind. The background liver, the problem here is not cirrhosis. But often these
You're
people
right.
have received extensive chemotherapy. You
Absolutely.
know that oxaliplatin gives you something like hepatic venous occlusive disease, and we've opened up patients and found the liver to be completely blue when
True.
you look at it. You know, where you just say thank you very much, and you
Yeah.
take out the laparoscope, and that's the end of the operation. Or you have something like irinotecan, which gives you a lot of steatosis within the liver. So the fine judgment here is in determining how much liver that you are leaving behind. The advantage of parenchyma sparing is that it lets you leave behind a huge amount of functional liver rather than doing a major resection. And oftentimes you would be as having a second or third surgery for colorectal liver mets.
Right.
So, multiple operations are possible in the patient. If you're parenchyma sparing the first time, then you have a lot of liver to fight with the second time
Yeah.
because, like the way trees get leaves, if you leave behind the portal vein branches and your liver regenerates around that, you can have a second go and a third go and a fourth go. And the patients where we have had five goes, at resecting colorectal mets, and they've done pretty well in the long run.
So basically, you have to, balance the oncological resection
Absolutely.
as the functional remnant liver.
Absolutely.
But the good part is that we've had a better understanding of the margins now, right?
Absolutely.
Earlier,
Yes.
we always thought 1 centimeter, 2 centimeter margin is essential for doing any liver tumor surgery.
Yeah. So HCCs we already discussed that a well encapsulated HCC, even the zero margin on vessels, is absolutely fine. You get the segment out and you're quite okay. Now, colorectal mets have always been interesting because they don't have a really good, regular structure. What you see on the scan is often not what you see when you do your intraoperative ultrasound. And if we aim for a 1 centimeter margin, the pathologist might tell you that at some points you have a 2 or 3 millimeter margin. So I think it's always wise to aim for a little more because at some point you're going to get close. And the problem is always the third dimension. If it's a surface met, getting the margins, on the surface is very easy. But the deeper margin makes the inexperienced surgeon a little bit,
Right.
reluctant because as you go deeper, that's where the bigger veins, the portal vein, and the hepatic venous branches come. So the care is to take deep margins. We would still aim for a 1 centimeter margin if possible, but we increasingly understand that even if you have a millimeter margin, it is better than not doing the resection at all. And
Yes.
now you have these beautiful surgeries. You must have seen the presentations of Professor Guido Torzilli, for example, who goes
Yes.
ahead taking out 22 liver metastasis. And
50.
and yeah, and it
50.
looks like, Henry Moore sculpture with
Yeah.
with multiple holes connecting to each other within the liver. So
Yeah.
he has publication that the way you have a zero vascular margin in an HCC, even a zero margin for a colorectal met on a blood vessel would be acceptable. But of course, we need, long-term results to actually validate this concept.
So interesting you mentioned Torzilli. So his last paper in Annals, I was going through that. So they looked at margins 1 to 4 millimeter, 5 to 9 millimeter, and more than 10 millimeter.
Yes,
And the local recurrence rates and overall survival were no different in any of these groups.
absolutely.
Think that, even 1 millimeter margin is good enough.
Absolutely.
As you said about the vessels also. So as long as there is a layer of liver tissue on that, or there is no breach of wall of the vessel, then you can
Absolutely.
clear that. But the ones with, sometimes they are infiltrating the wall or very
Absolutely.
close, and there is no sort of liver tissue or a margin at all. And in that case, either reconstruction, because those ones do poorly. Another concept which has come is that margin, even if it is positive, can be dealt with chemotherapy if those patients are responding to chemotherapy or
We don't plan for a
terminating.
positive margin,
Of course
but
not.
if we reach a positive margin, it's not the end of the world. You still get 5-year survivals in patients with positive margin after these operations.
Absolutely. The good part is that we have enough information before we go in. We have gadgets to assess the relationship and plan. What about the gadgets which help you do these?
Absolutely.
Again,
So
there's a dramatic, you know,
a shift in
evolution and uh, things at our disposal that we can get into these surgeries with more confidence because of availability of these gadgets.
Of absolutely. So, as you know, Sadik, cutting the liver has been the bugbear for 100 years. So, to do a neat liver resection, heliclysis was the gold standard for many, many years. And there have been excellent and skilled surgeons who've been very happy with doing
Right.
heliclysis. But with the evolution of technique, I think the big difference has been the CUSA. So this Cavitron ultrasonic suction aspiration device, which works by fracturing, hepatocytes and leaving behind the fibrosis which surrounds bile ducts and blood vessels, has been a real game changer. And if there's an instrument that I cannot do without, it is the CUSA. So there are techniques where if you're doing a hemihepatectomy, you can staple everything.
Yes.
There was in between a fashion of radio frequency
Yes.
assisted liver surgery,
Yes.
where
Yes.
you put in probes within the liver, and the way
Abhi.
you have an RFA for liver tumor ablation, you can ablate the parenchyma in your plane and then just take a knife and slice the liver off. There have been techniques, we've actually seen operations where you do a total vascular occlusion and just chop the liver into two and then just suture all the vessels you see and fold the liver on itself and stitch it. So this is the blast, whatever you see in your path. But that approach has never appealed to me
Mm.
because the neatness and elegance by which you can actually anatomically determine each vessel which comes in your way, each bile duct, ligate it or clip it or staple it as it comes within your path, gives you great precision. So I'm a great fan of the Kusa as far as this goes.
So another thing, Sudeep, I've noticed, while doing liver resection, I mean, we know that in trauma, all bleeding of liver stops. So
Right.
did we? I think it's more of the panic to control a bleeding, which leads to more bleeding and more bleeding. So I always tell my residents that, if there's bleeding from somewhere, just put a pack for 5 minutes.
Absolutely.
Don't rush there to do. And most of the bleeding, if you are in right planes, is controllable, doesn't happen, as you said, is if you ligate and go. So it's become more of a very precise anatomical resection. And then to add to that, you have the Pringles and all on and off, which you
Absolutely.
can, of course, use in the interest of not losing too much blood without the risk of doing a Pringle. So all these put together with all these gadgets, safe to say that it has become a safe
Yeah,
surgery.
it's interesting that you mentioned the Pringles maneuver, Sadik.
Hmm.
I'm a very sparing user of the Pringles maneuver. So a standard hemihepatectomy or a sectorectomy would not require a Pringles at all because you're controlling the inflow very beautifully before you transect.
Do that.
But I
Yeah.
think for the multiple colorectal mets where we are, you're doing multiple parenchyma sparing resections within, the Pringles is an excellent tool,
Yeah.
and you can really see well. And once you open it, if there is a little bleeder, it's easy to put a stitch in it and get that managed. This is a
I
very
agree
effective
that
tool.
for major hepatectomy is when you're getting extra hepatic control. You just do an ipsilateral kind of control. But segmental resections in cirrhotics, non-anatomical resections should not be hesitant to use a Pringles because
Absolutely.
it's a saver because you save blood loss and appropriately done with the proper timing, it's not going to cause a lot of liver dysfunction.
Absolutely agree, Sadik. So it's
For
better
that,
to preventively Pringle than to have to clamp the porter because, there's a big hole in the, in the
yeah.
portal vein which you're not anticipated.
Yeah. So, I mean, surgery has become safe and b- pre-operatively knowing how much liver you are leaving behind it makes it ensures that you avoid post-hepatectomy liver failure. So now, in your practice, do you get now PHLF any longer?
Un Unfortunately, however perfect you are, there will always be a small incidence. And the reason behind that is that we are pushing our boundaries. So
Right,
what used to be inoperable 20 years back, today we are operating on just because we have the tools and the techniques and the predictions. So
right.
again, there was, a man called Dominic Elias who was presenting from one of the great centers in France. So he
Mm,
showed a series of the first 1,000 liver resections, where
mm.
for colorectal mets, where the mortality was 2%.
Okay.
Then in the next 1,000, the mortality was 3%. So he said our mortality is not increased because we are worse surgeons,
Mm.
but our mortality is
Type
increased
of
because
case.
we are bolder surgeons. We are taking on older patients, we are taking on sicker patients, we are doing more redo resections. And we are just becoming braver in what we do because we are curing so many more rather than doing a conservative hemihepatectomy and ending it at that point. So I
Yeah,
think if you're pushing the boundaries,
right.
there will always be the odd patient in which you will run into a problem because all said and done, however well we try, there is no imaging, there is no functional assessment which is
Functional assessment. Correct.
absolutely perfect.
Absolutely.
And if you're pushing boundaries, there will be the odd failure. Our job is to keep that failure rate as low as possible.
Anesthesia is very critical for liver.
Absolutely, absolutely.
The anesthetists play such an important role. If you have a good
The anesthesia,
therapist,
pain management, the understanding of ERAS protocols. So I think minimal access surgery has really helped us in getting ERAS protocols understood that you can pull out the tubes quickly, feed the patient, you have very good pain relief.
so Sudeep, we do surgeries, we've evolved, we have taken it to the next level. But simultaneously, there have been several other developments, especially the ablative therapy for liver
Yes,
cancer, the immunotherapy. So now it's come to this multidisciplinary, multimodality approach to liver tumors. And that's also a paradigm shift, isn't it? You
absolutely,
have
absolutely.
options what to offer to
Yeah,
patients.
so this is very interesting because you have cases where you know that you cannot cure the patient, you know that you cannot cure the background liver, and these technologies essentially developed for this group of patients. So you started off with chemoembolization for HCCs which were inoperable. You moved to ablative energy source therapy, cryotherapy. You had the old-fashioned alcohol injection, which is still very
Yes.
effective for tumors less than 2 centimeters in size. And now, of course, you have the modern drugs, as you have mentioned, Sadiq. Now, the problem is to find out the precise role of each one of these, because the patient is always very tempted by being told that there's something non-invasive or minimally invasive which can be done. So you have a surgery on one hand, and
Yes.
you have a therapy on the other hand where, oh, you come in today, we'll just stick a needle in and you'll get out the next morning and everything will be fine. And especially a lot of these tools are not just within the surgeon's control. So if all the weapons are in the control of one person, you will choose your weapon wisely.
Yes.
We find
Yes.
that, when one specialty has only one weapon with them, they will find, the time to
Barber's chair
use that
phenomenon.
weapon in every case.
It's the
So
barber's chair phenomena.
absolutely. So here I think a multidisciplinary approach is extremely important. It is very important to realize what is our overall aim in this treatment, right? Surgery has been the gold standard, but for tumors less than 2 centimeters, especially in a cirrhotic liver, where you're likely to get more tumors later on, or a young patient who's likely to be a transplant candidate in the future,
Yes.
radiofrequency ablation or microwave ablation would be a very, very reasonable alternative.
Yes.
But we know today that if you have bilateral colorectal mets
Yes.
and you don't want to do a huge resection, leaving a
Deep
very
sea.
small amount of chemotherapy, hit liver behind, then a combination of ablation and surgery is a very effective approach to these tumors. Or if you're trying a volume expansion, For example, if you're going ahead with, doing a portal vein embolization to
Organization.
hypertrophy segment 2 and 3, and there is a spot in segment 3, you can easily do an ablation of the segment 3 spot because tumors will grow 8 times faster than normal liver as the liver regenerates. So
Yes.
you can use this as a combination tool. So it's important to see all these advances in perspective. Now, the drugs are an interesting example. So when the sorafenib paper came
Yeah.
in, and that's actually one of my favorite examples.
I
So
know.
as you know, Sadik, I love to discuss how to critically analyze a published paper.
Yeah.
That's way beyond the discussion of this group. But the sorafenib paper is the classic paper that I would discuss.
Yeah.
Perfectly written in one of the great journals, the New England Journal of
New England
Medicine.
Journal.
Yeah.
Yes.
But when they marketed the drug, it made it sound like it was
Wonder Drug.
magic. It dramatically increases survival, 30% survival benefit for hepatocellular cancer. But the actual delta was only 6 weeks
Yes.
in a bunch of inoperable tumors.
Weeks
So
of
sorafenib is a useful adjunct, but it has never cured anybody.
true.
Modern immunotherapy is a very interesting concept for people who tolerate, Atezbev or Durva. It's a very good tool, but we still don't have the information whether it can completely replace any of our ablative or surgical tools. So we have to watch the
No.
space carefully. Whenever any new innovation comes in, the first step is to think that we have to watch carefully. Everybody wants to use it because you want to sound up to date and you want to give the latest treatment to the patient. Then, because everybody is using it without some of them understanding its true utility, you
Mm.
get a lot of complications. Then
Yeah.
you think it's the worst thing ever. And then, over a period of time, you find that this is the true slot for the reason. And radiofrequency ablation is the classic example. As you remember when it was launched, everybody tried it because, I mean, who wants to operate on a cirrhotic patient if there's an alternative? People said you can ablate 8 centimeter tumors by putting in
Yeah.
3 passes and 4 passes, not realizing that, within the liver, 8 centimeters is a huge space. You double the size of the tumor, the volume increases 8 times. So the energy you're delivering is also 8 times, which is a massive hurt to the tumor. Then you had a spate of ruptures, biliary complications, abscesses, incomplete ablations, which you just couldn't salvage. And
Mm.
then we have come down to a current criterion that below 3 centimeters is the best way to use this. So every technology goes through this paradigm shifts of being, everyone should try it, the worst thing, and then this is the true role in management, and it's incorporated into our algorithm. So we need to understand where we are with the technology, understand all the pros and cons before we offer it to our patients, which is why it's important for us to critically analyze all the literature we have today on the subject and to cautiously offer this to our patients and making sure that these patients are managed within a multidisciplinary team with constant monitoring so we can back out if we think that we are not on the right path. But we need to keep advancing, Sadhu.
Yeah. But another thing, Sudeep, what I see is like everyone will talk about that you should go to a liver specialist surgeon. And so we go to those people, they do the job, they are adept at doing it, they've been doing it all along, and that is well accepted. But we don't demand the same kind of expertise for these ablative therapies. Every person who starts putting a needle thinking that I know the ultrasound and I can do the ablation. And the success rate is not uniform because you are not able
Absolutely.
to
Yeah.
achieve the same ablation because you still need expertise. And therefore,
Absolutely.
unless you are an expert or you have developed or gained that expertise in doing ablative therapy, I don't think it is safe in anybody's hand, just like a liver surgery is not safe in everybody's hand.
Absolutely,
And as
Sadhu.
a matter of fact, there was a paper, of course, in the initial phase of it, when these lesions were resected, almost 60% had viable tumors, RF ablation. This is the RF ablation kind of
Yes.
this thing. So I feel, again, it is a security blanket used by patients and some of the physicians, which say that it's non-invasive rather than a invasive liver surgery, but not realizing that who's doing the ablation. And I feel it is equally important that who does the ablation should be as adept as a liver surgeon.
So it is never about the I anymore. It is about us as a team. And I think it's the duty of all of us to make sure that the patients are sent to a system where everybody knows their job and they have the confidence that if they come to place X, they will get optimum care because everyone knows what job that they're doing.
Yeah. Yeah, so I think that multimodality and multidisciplinary approach is what the new mantra should be for this.
Absolutely.
Sudeep, tell me what got you into this liver surgery. I mean, why I'm asking is that in the era when we started doing, it was a thankless surgery. We didn't have all the gadgets. We
Yeah.
didn't have that. But of course, we learned over time. We kept ourselves updated. But how did you, sort of channel all your energies to this in terms of?
No, no. So it's an interesting question, Sadik. So see, when I was a young and foolish, trainee, the desires to do things which you don't see regularly around you. So as you said, it was a thankless surgery, but I think it is no longer a thankless surgery,
Yeah.
and I'm so glad to be part of that evolution that I had training with a chief interested in liver surgery in India, Dr. S.K. Mathur. I went abroad and I saw many liver surgeons. So I think that's the fun of being a surgeon, that the gratification that you're helping things move along and you're giving a good quality of care to patients who had no hope 20 years back is, I think, why we are all surgeons.
Another thing I want to talk to you, I mean, a lot has been spoken about this, the Barcelona clinic liver
Right,
classification. Over a period of time, despite the modifications, and they've had to make modifications, we realize that things are not in such straitjacket that we follow that. So I want you, as I said in the beginning, that you have this very critical and analytical bend of mind to look at articles. So I want to hear from you. What do you think about the BCLC and
right.
how it is relevant to clinical practice?
Yeah, so that's an excellent question, Sadik. So one must understand the background in which this BCLC was actually formulated. So as you know, in Spain, there's this big group doing fantastic work in liver tumors, and their main volume of work was in hepatitis C cirrhosis, which was rampant at that time in Europe. So they came about this broad guidelines of what should be standard of care in an algorithmic manner. And because it was, very specific, very clear, it was easily adopted in the Western world. The East never ever accepted the BCLC because the disease spectrum is different. So you have the hepatitis B virus, which was much more prevalent within the East. So
Yes,
what you can aggressively resect in a hepatitis B, having a perfectly good survival with low morbidity, you probably cannot replicate in hepatitis C.
absolutely.
Secondly, the East never had the freedom to do cadaver transplant the way the West had. So probably they would have a more aggressive approach to resecting tumors
Yes,
because you wanted to cure without transplant. And also, if you're beyond transplant criteria, what if you're 70 years old? Would you be denied an aggressive treatment and a chance of living to 85 just because you are not within an algorithm? So we have to understand these limitations. So as you know, there's the Hong Kong criteria, which are a little more liberal in what you're allowed to resect. And it's interesting that you asked because my last resident, Sandeep Joel, his thesis was comparing BCLC with the HKLC criteria
mhm,
for our own population in India. And we found that the HKLC criteria, which are a little more liberal to what you can resect, actually fit the population a lot better. So we
Yeah.
really need to individualize within a broad framework guideline and not follow BCLC like it's some religion or,
Yeah.
the Ten Commandments handed down, from a Spanish mountain to us. And if you notice, the BCLC guideline is always quoted in medical publications. You will
Mm.
not find that many surgical
Yes,
publications
yes,
from India and the East
I agree.
quoting the BCLC.
So, how do you suggest? Suppose I'm starting my journey as a GI surgeon and I'm interested in this, how I should carry on or evolve or develop my skills so as to be able to deal with these patients independently.
Okay, so that's a very good question, Sadik, and that's a question all of us face. It's not just the starting surgeon. I mean, I'm facing it today as well, that how do I stay updated in what I'm doing? So I think the advantage we have today is the amazing resource availability. So we have much more freedom to meet people, visit centers, be online, see, videos,
Yes,
interact with people. I mean, something like
agreed.
this, podcast. Yeah, I couldn't imagine a podcast in my residency days. So one needs to be antenna to be raised to understand what is going on, and not only to see all this, but also to critically evaluate that is this a genuine advance. So if you say that there is AI augmented reality superimposing on the liver, is it worth doing today? Or
Mm.
is there a distance for it to go? So you need to have the pliability in your mind to be questioning, to be open to future developments, to use all these online resources available to you to absorb what is new, what is evolving, but also to be critical to see its role. I think that would be the message, Sadik.
To my mind, very important that, oftentimes people think that, look, watching videos and all, you can then start doing that. But I think to spend time with people who are doing it regularly, because the planning, how they go about it and how the patient gets to the table, that part is equally important or maybe
Absolutely,
more
absolutely.
important. Thank you, Sudeep. I think I have 100 more questions. We have not even talked of minimal invasive surgery and all that, but I guess we need to get you back again sometime to discuss many more things. But thank you for sparing your morning with us. And as always, it's been a pleasure talking to you. Thank you.
And thank you, Sadik, for that very interesting series of questions. And I'm really happy to be part of this podcast.